Welcome, Tiago, to this videocast. Could you please introduce yourself and tell us about your professional experience?
Yeah, hi Hugo. Hi everyone that is watching this little video. So I'm Tiago Maricoto. I'm a family doctor in Portugal, in a small city called Aveiro, a small coastal city in Portugal. I've been working with IPCRG in some groups, mainly in the Sentinel network, where we develop answers for respiratory and COVID-related topics in a practical and clinical-driven manner. I've been also involved in the designing and planning the COVID clinical care unit here in my town, and also in the local vaccination center. So it's a topic that I've been working since the very beginning. And I have also been involved in Portuguese groups dedicated to respiratory field and respiratory issues, mainly asthma, COPD, and inhaler technique. So this is a brief resume, I say.
And it's perfect because this is a course on COVID and COPD. So, well, who else could be better to have with us today? And on this module, the case study focus on the follow-up and rehabilitation of patients who have experienced severe COPD exacerbations triggered by a COVID-19 infection. So let's switch our focus and use a couple of minutes to talk about the initial assessment of patients with stable COPD presenting to consultation with symptoms suggestive of COVID-19. What should be done differently to address these patients compared to COVID-19 patients without COPD?
Well, patients with COPD are at an increased risk for severe illness associated with several viral infections, including COVID-19, and at an increased risk for progressing to severe COVID-19 disease and also death. So these patients have a higher risk for a rapid worsening of symptoms than compared to a usual COPD exacerbation caused by other triggers. I'm talking, for instance, about symptoms like dyspnea, cough, sputum, fever, fatigue, weakness, disrupted sleep patterns, or acute anxiety. So this leads to a higher risk for more severe events that may lead to hypoxemic respiratory failure and to the need for advanced care, such as oxygen therapy, non-invasive ventilation. So it's very important to perform a full body examination on those patients, seeking for vital signs, sudden respiratory and cardiovascular distress, neurological and musculoskeletal changes, for instance, skin changes, and also a prompt screening on major comorbidities. So this is the relevant thing to clinicians to address on these patients differently than they will do outside the COVID context, I will say.
That's a very good core message. These patients are at higher risk and should be treated as such. And as you were mentioning, we also need to be vigilant and make good decisions on when to send these patients for more advanced care. And in the case study, we discussed warning signs that would warrant hospital assessment for these patients. And I would like to go a bit beyond that and see if you have any other advice for primary care physicians who for any reason are uncertain about referring the patient for more advanced care or to just manage them with them in a primary care setting.
So I think, as I mentioned, the crucial thing to do, it's a full examination, and that's crucial to seek for warning signs that indicate the need for hospital assessment. However, that's not easy to do in primary healthcare settings to perform such complete evaluations because some parameters may be difficult to check, such as oxygen saturation levels, for instance, which is a key predictor for respiratory failure. So at some point, clinicians need to follow their clinical instinct and judgment to assess somehow the predictability of severity for each patient. And that is why it is so important that primary healthcare providers know well their patient's profile, and that's somehow the main corner of family doctors, for instance, that know their patients for several years. And that's crucial to evaluate the relevance of some clinical changes over time and of some new symptoms that may be somehow red flags. In doubt, COPD patients should be referred to an emergency room, even if, after all, it is confirmed a mild exacerbation without the need for advanced care. So we may need to play for extra safe measures instead of letting those patients without the proper evaluation.
Yeah, when we are talking about the stable COPD, primary care, IPCRG has been consistent in sharing messaging that primary care is at a very good spot to have a care that's long-term, where you get to know your patient, where you get to know what changes there are. And things change a little bit when we go and talk about a COPD exacerbation, right? Which was the focus of this module. Patients living with COPD who experience exacerbations, for example, are likely to present long-lasting symptoms as well. And this may be called post-COVID-19 syndrome, but it also occurs with other infections. It's not specific for COVID-19. So can you talk a little bit about this as it pertains to COPD patients?
Well, yes, this has been an emerging issue since the COVID pandemic. And in fact, the long COVID condition is defined overall as the persistence of symptoms over 12 weeks following the acute illness. And the estimated prevalence of it varies considerably among different studies, ranging from 5% up to 80% of patients in different settings. The most common symptoms include fatigue, dyspnea, cardiac abnormalities, cognitive impairment, sleep disturbances, symptoms of post-traumatic stress disorder, muscle pain, headache, concentration problems. So those are the most frequent ones, and that may last longer. And some studies, in fact, suggest that COPD may be associated with an increased risk for long COVID. I guess the estimated risk ratio is about 1.4 in some pooled analyses, as well with symptoms resistance and persistence up to 12 months after hospital discharge. So this is particularly relevant in higher risk patients and in patients with worse COVID illness. So when we consider persistent symptoms following an acute COVID-19 illness, it's important to rule out other causes before assigning them as part of post-COVID syndrome itself. And here, COPD is a good example of something to address in detail, to check whether those symptoms are mainly due to the COPD status of that particular patient or mostly due to the COVID, the post-COVID condition. So it's difficult to do, but it's an exercise, a clinical judgment to do. And that's why it is so important to follow up these patients after an exacerbation, mainly at the first month and after 3 up to 4 months, which is addressed in this model, because this will allow to evaluate coping abilities, treatment adherence, inhaler techniques, symptoms burden, physical status, comorbidity, lung function, and the overall prognosis for that individual and particular patient.
Right. And once we manage to, in the cases where we manage to say, well, this looks as a post-COVID-19 case, we have looked at potential differential diagnosis. And now it's time to support this patient on his recovery. One of the key elements of recovery is physical activity and pulmonary rehabilitation, especially in cases after exacerbations. And do you have any advice to for physicians to support their patients to better engage on physical activity?
Well, we see that fatigue, shortness of breath, and cough, for instance, are the more relevant and prevalent symptoms and persistent symptoms among people who were hospitalized with an acute COVID-19 illness. For instance, to give you a clue, at 8 months follow-up, fatigue is still present in up to 60% of patients, and shortness of breath in up to almost a half of patients. So it's something very relevant. And for those patients who do not require hospitalization, fatigue and shortness of breath may also persist over and beyond the 6 months after the acute event. So these highlight the importance of physical activity and pulmonary rehabilitation for those patients, because it may play a key role as it significantly improves physical capabilities and quality of life. However, those patients may take some time to experience those benefits, and this might lead them to quit the programs very early. And we need to explain them very careful that those programs and the recovery of those symptoms, it will take time, and they will probably need to maintain it for several months. So we need to engage them and motivate them. That's the tricky part, to get the patients engaged to those programs to get the real benefits. We are starting to see many studies addressing maintenance and long-term rehabilitation, pulmonary rehabilitation programs, and they really improve quality of life and functional status. Yeah.
So mental health is also very important in these cases, not only to protect their patients' mental health, but also because we have seen that mental health is directly related with treatment adherence, with prognosis, and even mortality risk. So how can physicians best support patients with symptoms of psychological distress?
Yeah, in fact, COPD patients often suffer from anxiety or depression. Those are major comorbidities. And that is particularly relevant after a major event such as an exacerbation, mainly if it is moderate to severe. Also, anxiety and depression increase the risk for long COVID syndrome. So we have studies reporting risk ratios of up to 1.2, a slight increase for long COVID syndrome. And this includes, for instance, the persistence of some key symptoms such as dyspnea, shortness of breath, and thus impacting quality of life. So it's very important to clinicians to be able to identify those symptoms, to treat them accordingly, and whenever it is needed, to refer those patients to secondary care, because those symptoms may last several months and may be difficult to manage, and they are somehow related to physical manifestations. We have here a very strong somatic link somehow. So primary care physicians need to deal with that and to treat and refer whenever it is necessary. Yeah.
Yeah, and this is one of the many factors that we need to look at in these patients. A holistic approach is something primary care should strive for. And as part of that, of course, we have pulmonary rehabilitation, physical activity, treatment adherence, we have mental health, and always important to think of comorbidities. We know that over 85% of adult patients will have at least one clinically relevant comorbid condition, and 50% will have 3 or more. So how can physicians feel assured that sufficient investigations have been done to enable a safe rehabilitation and safe recovery in these cases?
Well, so we have talked about the benefits and the importance of rehabilitation, physical rehabilitation and pulmonary rehabilitation after such an event. And we have overall, at least in Portugal, I see that reality here in the field. But overall, we have an issue that is the lack of referral of those patients to those programs. So a few part of those patients, slight part of those patients get access to it. And we need to bring more and more to them the access to those programs. But when we do it, we need to address the comorbidities that patients have, because a key comorbidity, for instance, that may affect the safety of a pulmonary rehabilitation program is the cardiovascular status overall, mainly regarding cardiac impairment. I'm talking about cardiac failure, previous and recent acute coronary syndromes, severe arrhythmias. Those are conditions that may impair or somehow condition the safety of a rehabilitation program. So it's very important to primary health care physicians and clinicians to check those earlier. But also COPD patients after an exacerbation may experience other symptoms and other situations, such like symptoms exacerbation. Those are issues addressed in this model somehow, but often those patients may have orthostatic intolerance, exertional desaturation, and post-exertional symptom exacerbation. For instance, those are conditions that may be related to some key comorbidities, such as asthma, anxiety, depression, chronic fatigue, metabolic syndrome. So those patients need to be managed carefully during the start and during the follow-up in a rehabilitation program, and they must be monitored for signs that may indicate a worsening of their status. So I will say that a full and comprehensive management should be done in order to achieve the best clinical control over those comorbidities, not only treating those comorbidities, but also being aware and vigilant over them, avoiding some worsening for each one. And probably in some cases, it will be needed to adjust the rehabilitation programs accordingly to each case. Yeah.
For those who are only taking this module, we have another module on post-COVID-19 where we elaborate on all these conditions, even though these are introduced in this module as well. Thank you very much, Tiago, for all your support in the development of the case study on this videocast. It has been amazing. And as we wrap up, do you have any additional advice or insights that you would like to share with our students as they continue to manage patients with COPD in the context of the COVID-19 pandemic?
Yes, I would like to leave some final messages, some key messages that I think are important. I would highly recommend our fellows to encourage their patients with COPD to ensure they take their medications as prescribed, and to report any increase in respiratory symptoms very promptly and early in order to address them before the escalation to an exacerbation and to a worsening of symptoms. It's very important to continue to follow up patients once they recover from an acute COVID-19 illness of any severity, because those patients are at higher risk for long COVID syndrome, and pay some particular vigilance for symptoms persisting beyond 12 weeks, which will be not very normal, and consider appropriate assessment and referrals to secondary care whenever it's necessary. And finally, last but not less important message, to recommend routine vaccinations to those patients, not only the vaccination to COVID-19, but also influenza, pneumococcal infection, pertussis, but also herpes zoster. So those are all recommended by international guidelines, and they will help to protect more our patients.
Tiago, thank you very much. It has been amazing, and see you next time.